Everybody hear me okay?
Yep.
Great. Thank you all for joining us today for this webcast, Telemedicine Adoption, a Virtual Shot in the Arm in the Age of COVID-19. My name is Craig Ball, and I'm the Director of Strategic Investments and Transactions for UPMC Enterprises. I'm also a board member of the PVCA Emerging Leadership Board. Before we get started, I'd like to thank the PVCA annual sponsors. We would not be here without their generosity, and especially at this time when things are uncertain, we are very grateful. If you're interested in becoming a sponsor, please contact Micah Whitfield, the PVCA's Director of Business Development, and let her know. We have some exciting virtual events on the horizon as well as some potential in-person ones. There is also free membership for an individual under the age of 40 that comes with your sponsorship. Now, moving on to today's event, our webcast features three outstanding experts in the arena of telemedicine. Dave Zinn, President and CEO of Infectious Disease Connect. Paula Price-Zemski, Administrative Director at UPMC Center for Care of Infectious Diseases. Dan Godla, Founder and CEO of ThoroughCare. By way of note, if you have any questions for our panel during this event, please use the Zoom Q&A function and we'll respond to as many as possible near the conclusion of the webcast. At this time, I'd like to turn it over to each of the speakers, Dave, Paula, and Dan, to provide a brief background on each of themselves.
You to go first, Craig? So hi, everybody, and thanks for joining us. My name's Dave Zinn. I'm the President and CEO of Infectious Disease Connect, Inc., here headquartered in Pittsburgh. We are a telemedicine company that provides specialty infectious disease care to rural hospitals. So we're more of a B2B model, which we'll talk about shortly. There's a shortage of infectious disease specialists that hits those markets harder. And what we in effect do is invert the old model, which was if someone was sick in a rural hospital, they would be shipped via ambulance or a helicopter to a larger city facility where there were ID specialists. We now take those ID specialists and through telemedicine bring them to the bedside at the rural and community hospitals.
Hi, I'm Paula Zemski, and I work for UPMC, the Center for Care of Infectious Diseases. I'm the administrative director, which really means that I run the operations for a very complicated department. One of the things that Dave and I have in common is that we share a number of our physicians. Many of our physicians who see patients here at UPMC also support the physicians through ID Connect, or support the patients through ID Connect. So one day they may be working in clinic, one day they may be working on telemedicine for us here at UPMC, and then one day they may be supporting another hospital somewhere across the country with ID Connect. So it's a lot to try to keep your arms around. Anyway, I've had a special love for telemedicine for a number of years, coming from the revenue cycle and having done a lot of research into reimbursement and compliance, helping to develop some of the policies. So moving into ID was just a natural progression for me. Thanks for joining today.
And my name is Dan Godla. I'm the founder and CEO of ThoroughCare. ThoroughCare, we're a Pittsburgh-based company. We're located downtown. We have about 15 employees. And we help doctors stay engaged with their patients in between appointments. So there's, particularly on the Medicare side, there's a lot of programs that doctors should be doing, but they're not sure how to do it. They don't have the software to do it. And that's where we come in and give them software that makes it easy. We train their staff. And we'll talk more later about, particularly how COVID has affected that. But the goal is to make it so no doctor has a disconnection with their patient, especially when they're not able to get to the clinic.
Great. Thank you all very much. Appreciate it. So before we dive into some of the heart of the questions surrounding telemedicine, Dave, it may be helpful for the audience if you could provide us a background of what telemedicine is, the benefits, and a few of the challenges that we see in the industry today.
Sure. So at its core, telemedicine is basically the diagnosis and treatment care of a patient through telecommunications. And that can take the form of a live audio video consult where the patient and doctor are seeing each other and interacting live or synchronously. That could be asynchronous, which is sharing of pictures or x-rays and notes. And it also could just be telephonic. The benefits are largely the convenience and efficiency. If you're a consumer, you don't have to go into an office, you don't have to drive, park. You can do a very efficient treatment plan. Same for the doctors. The doctors can see more patients more efficiently through telemedicine. And I think, we'll talk about this, I'm sure, but with COVID, they've learned more about how they can see doctors or see patients efficiently. So it is a very efficient, very effective way of seeing a patient. The challenges have been over the years, regulatory requirements, basically every state, and you throw Washington, D.C. into there. So there are basically 51 different government bodies that control telemedicine, different definitions, separate licensing rules and regulations. And reimbursement has historically been a bit slow. And that was a little bit of an issue for doctors and hospitals and providers adopting as quickly as maybe consumers had wanted. But that, in a nutshell, is telecommunications, telemedicine. We have seen, who knew, we've been talking for years about the adoption, and in that, that year where we really saw the adoption rate increase. And I guess who knew it was going to take a pandemic for that to happen, but I think it truly has happened in 2020.
Appreciate that. Dan, you had provided a short overview of ThoroughCare via your introduction, but could you explain a little bit more how you fit into the broader telemedicine value chain with ThoroughCare?
Yeah, I'm happy to. And I think, as Dave mentioned, telemedicine is historically sharing video or pictures, but it's a lot of other things too. If you've expanded it, maybe the patient has a device that sends data to the doctor. So, I might expand the definition of it to say any way that the doctor could share info with the patient. And we see a lot of that on our end, particularly in the Medicare space. These are seniors, and the question is always, will a senior, do a telehealth visit? And, we thought so, but we weren't quite sure. But sure enough, with the pandemic, it's happening more and more that regardless of the age, almost everyone has a smartphone. Almost everyone has, the ability with a camera and a microphone, and they can start taking advantage of some of these things. But we see it particularly in our side, we don't do as much of the video chat, but, we help the doctor give their patient a blood pressure monitor. And the patient takes their blood pressure every day, and the numbers flow back to the doctor. And sure enough, if they get a high reading or your systolic is, over whatever level you set, maybe 180, your doctor gets an alert. Cardiologists are giving scales to their patients, seeing if there's any rapid weight gain that maybe could prevent a stroke. Diabetics check their blood sugar every day. So I think there's a lot of, if we expanded the definition of telemedicine, any way that you stay connected with your doctor, I think is a good thing. And like Dave said, it took a pandemic to get to this point, but we hope it sticks around. We're seeing good feedback from both doctors and patients so far.
That's great. That's great. So Paula, with that being said, being a leader at UPMC, what are some of the examples of how UPMC leverages telemedicine across the payer and provider networks?
Okay, great question. So, I'll start early on. One of the things that UPMC did, for many years was just basically help to manage patients who were in the hospital having had a stroke. So stroke care was an early use of technology and telemedicine. Over the last 10 years, though, we've slowly been adopting. And so one of the first places that we started are with telemedicine video or telemedicine visits where a patient is in a remote area. Medicare agreed to pay for telemedicine for patients who had a hard time. They were in a health provider shortage area. So we have patients who go to telemedicine centers or physician clinics that are set up with cameras and audio devices, and the physician remains here in Pittsburgh. They see each other through camera. There is a telemedicine presenter who is with that patient who can help with things like the patient's physical exam. So that was an early use, slow to adopt, but we use it pretty consistently every day. Last year in 2019, UPMC really was working hard to get patients to start to use video technology where they would use their cell phone or their smart device to be able to see their patients on camera. As Dave had mentioned, reimbursement was a bit of an issue for some of that, and Medicare was not willing to pay for a patient to be at home. They wanted those patients in health provider shortage areas. So we were at a little bit of a loss. UPMC Health Plan, though, we work very closely with them. They were very supportive. So we started this effort in 2019. Slow to get the providers to adopt those, slow to get all of us to adopt to it until COVID hit. And now all of a sudden we see a ton of patients on video to the point where it's really eaten into those patients who went to the telemedicine centers. And then I want to mention too, what Dan had said, one of the things that we do at UPMC is a lot of the remote monitoring that his company is involved with. And I can tell you that is very hard to operationalize because of the workflows. It's very complex, but we are finding opportunities to use some remote monitoring for patients with chronic conditions. And within ID, we use it a lot for our patients who are on long-term antibiotic therapy. So we all have a lot in common here.
Great, great. So as our program namesake mentions, I want to talk a little bit about telemedicine in the age of coronavirus and the various challenges to the market, to the industry, etc. So with that being said, Dave, what are some of the changes that you've seen over the course of the last 10 months as COVID has increased the broader adoption of telemedicine by both providers and consumers? And more importantly, do you think this change in behavior is permanent?
So as Paula mentioned, with COVID, there was a real, a strong emphasis on not having patient-doctor, patient-nurse interactions if you didn't have to, only in emergent situations. So what happened is, everyone was sort of forced to do remote visits or telemedicine visits. And so everyone saw an increase. Luckily, there was emergent regulation changes that gave reimbursement, reduced some of the regulatory requirements, and allowed for people to stand up their telemedicine services a lot faster. And I think what came out of that was, again, it was people, both the providers and the consumers, realized that this was a very effective way of treating patients and seeing your doctor. I think the doctors, in my opinion, mostly the acceptance and adoption that increased was on the provider side. I think a lot of doctors were hesitant to take on telemedicine, both felt like it might cannibalize their existing business. Maybe it was just change management. Maybe there was this overhang of, is it a quality care issue? And I think being forced to do this through COVID, everyone has realized it's very high quality, it's very efficient. It doesn't replace seeing your doctor in person for annual physicals and those types of things, but I think it's an and. It's seeing your doctor in person and taking advantage of technology. Do I think it's going to be around? I do. I think this is truly that inflection point that the industry was looking for. General acceptance. Medicare has been reimbursing under emergent rules. I think that will become permanent. Your insurers are now starting to look at this more efficiently and effectively. So I think that, I think what we'll see is probably as we get back to normal, there'll be a slight decline in the number of visits because patients will come into the hospital and to their offices, doctors' offices. But I think what we'll see from here on in is, kind of just a steady increase in expansion of the use of telemedicine.
Helpful. So Paula, as UPMC was forced to adopt telemedicine, as Dave said, probably most from the provider side, could you, and probably, they adopted it probably a little bit quicker than anticipated. What were some of the challenges they faced to meet consumer and provider demand?
So there's a number of challenges. One of my physicians fondly calls it the digital divide. And as Dan had mentioned earlier, a lot of our patients are elderly. And so some of the technology has been a little challenging for them. It's easy for us to look at a workflow, to look at, say, okay, doctor, there's a camera, you're going to see it, the light's going to be green. The patient may not exactly see the same thing at the same time. So not only do the patients need to use a particular platform, but if there's any technical issues, it may be challenging for them to overcome some of those. There's etiquette is another thing that we really didn't think about early on, but and time management goes right along with it. So patients now who you can see on the video screen may be more inclined to want to have more personal conversations with the physician who may have other patients stacked up either on another video call or in the waiting room, and trying to move that patient along and be polite and still get things accomplished, or some things that we're still trying to work through. And those are certainly things we hadn't thought about. Another thing is with COVID, everybody became a prime candidate for virtual medicine. But that also meant that there are some patients that needed to have some in-person care that ended up being deferred. So we have a population of patients in ID that are primary care type patients who right now they need their flu shots, they may need to have their labs drawn. And even though through virtual medicine we can order those services, the patient may not be as inclined to go and take care of them. So there's things like that. The other thing that I'll just touch on briefly are the platforms. So, we are very cognizant of making sure that we're using HIPAA compliant software that integrates with our EHR. But during COVID, when we rapidly had to deploy this, sometimes that technology did not quite work. And Medicare's emergency programs allowed us to use some other platforms that may not be as compliant. So we found things that were close that we could use, where you could click a link with a patient and have them use it. But when things ever get back to normal, we may have to undo some of the behaviors that happened during COVID. I do want to ask you, is this the time to show the slide?
Sure.
So this is a really powerful picture of what happened with telemedicine in the Department of Medicine, which is ID falls under the Department of Medicine. So if you look at this slide, the purple bar is really our face-to-face visits. And as you can see, we're at about 725 encounters per day. If you look at the note, first case in Allegheny County, you can see we were still face-to-face. But after that, look at the orange bar. Everything that was face-to-face shifted to virtual medicine. So we're still seeing the same number of patients. There was a blip, but we're still seeing an average of 725 patients a day. And during that period, when we were in the throes of COVID, we were seeing most of our patients via telemedicine and most likely through a video visit. So thank you for sharing that.
Paula, has this trend continued? I know the graphic is from the first week of June, but throughout the summer and now the early part of the fall, has this trend continued?
Not to this extent. So, once we found that it worked, and because there's some financial benefits to using telemedicine, which I could talk about at another time, but our goal is to keep our visits at about 30% as a minimum virtual, and that's where we're hovering right now. So 70% of our patients are coming into our clinics, 30% are being seen virtually.
Got it. And are these, is this adoption for the telemedicine visits, is it centered on any particular specialty, or is this more across the board?
So I'm looking at the Department of Medicine. So for us, I think it's really across the board. Some specialties work way better. And, early on when we talked about trying to gain adoption, even with our physicians, Dave had mentioned this, physicians were worried, this patient may not be a good candidate for telemedicine. We need to do a particular level of physical exam that we can't do virtually. So what we did was we spent a lot of time thinking about what was the appropriate use case. We're not quite back there anymore, because now what we've seen is that providers have adopted, and there's some things that we can do to enhance that. But, it does lend itself well. Originally our thoughts were these should be mostly talk visits. Behavioral medicine is great for virtual medicine, but what we've really found is that it really does go across the board, and we can go beyond those individual use cases. I hope that makes sense.
No, that was a helpful answer. Thank you.
Sure.
So Dan, on everybody's mind is who pays for this? So can you give us a quick overview of how telemedicine has historically been reimbursed from private and public payers, and how this has changed during the pandemic? I know Dave had briefly touched upon this, but can you dive in a little bit more for us?
Yeah, telehealth isn't new. It's been around for a while. It just didn't pay much, and no one wanted to do it. I think it was like $12 for a telehealth visit. So if you're an independent doctor and you get paid when your patients come in for visits, do you want them in the clinic when you can bill an E&M, or do you want to do the $12 remote visit? And so the change that happened in March is, at least I'll speak to the Medicare side since I'm most familiar. Medicare said, we'll count it as a regular visit. So, you do that, and, you take down that, there's no reason to not do it. And the doctors really, they needed to do it because they're seeing their visits drop. And so everyone thinks that, during COVID, doctors are seeing more patients than ever. And, the stats are saying that your patients aren't coming in for their regular visits. Your chronic patients that have regular checkups, they don't want to be in the waiting room with sick people, and they're staying home, and they're the people that need these visits. And this now gives doctors the tool they're financially incentivized to do it now. And so most health plans and even Medicare, they'll pay. Very few times the patient would even have an out-of-pocket for this. So the doctor makes money, the patient, and it took an event like this, but it's exciting for the doctors because that lost revenue would have really hurt providers, especially the ones that are still independent, and there's still a lot out there, but they need their regular patients to be seen and managed, and that's good for the long term. If you have a chronic patient that is not getting the care they need, they're more likely to be admitted to the emergency room at some point.
That's helpful. So given that the audience today is more venture minded, I definitely want to dig into a little bit more on the investing landscape. So Dan, it would be interesting for us to get an entrepreneur's perspective on how VCs look at this space. We know that in the first quarter of 2020, that venture capital funding for telemedicine rose to $788 million, and there's no signs of slowing down as a result of COVID. Again, a lot of this was even pre-COVID, a lot of money pouring into this space. And so given the amount of capital in the marketplace today, what do you think VCs are looking for when investing in a telehealth company? Is it something like the size of the overall market opportunity, a niche service line that they can package on a platform? Is it provider versus consumer facing? What's your take on this?
Yeah, it's an astounding number, what, 788 million, and you look at that, I think it's the fastest growing segment of venture. I should note a lot of that is big players getting bigger. I think Amwell raised 200 million out of that. Doctor on Demand 75 million. So the big players are getting bigger, and they're trying to compete with Teladoc, who's a big player. But a lot of the smaller companies, they're raising smaller rounds, but they're seeing increased interest from VCs. We're going through it as well. We're going through a Series A, so I'm familiar with the questions that are being asked. Obviously, every business, how are you handling COVID? So, COVID has impacted a lot of businesses nationwide, different industries. How has your business stood up over time? Has revenue dropped? Has revenue increased? So telemedicine is fortunately an area where tremendous growth is happening despite of the pandemic. However, VCs are asking what happens when things get back to normal. So is this a fad? When I can go back and see my doctor, are these companies gonna going to go under? And it's a fair question, right? You hope that this stays. I do think it took something like a pandemic to get to this point, but the case that VCs are asking us to make is, can this hold up in the long run, or is this just a fad?
Right. Dave, I pose the same question to you. What's your take on the amount of capital going into telemed right now, and where do you see it continuing over the next 12 months?
Yeah, it is a phenomenal number, and I agree with Dan in that some of the big players have been on an acquisition binge, and they've been funding themselves. But there's a lot of new startups that have been funded in the last couple of years. Our company being one, we've done 2 rounds in 18 months. And the interest level, I've been in this industry for 10 years now, and it used to be that, and I would say overall, the venture capital private equity world got the model, and they knew that it was going to be a model in the future. The question they would always ask is, when is that adoption rate? When's it really going to hit? Because if you're an investor and you make a bet that it's going to happen in 2 years, but it takes 7, that's a lot of capital that you might have to put into a business until it hits that break-even point. And I think that was one of the things that caused some people to be a little bit more stringent in making investments in the industry, was just the adoption rate. So I think we've answered that question. I think the adoption rate has we now have full adoption of telemedicine. And I do agree, and I said this earlier, I think we're going to see, when we get back to normal, volumes will probably go down because it'll naturally transition a little bit more back into in-person care, but it's going to be much higher than it's been historically, and then rightly so. I think we'll just see continued just normal growth of telemedicine, and I also think we'll see investment and we'll see R&D to expand the services and what you can do. So. I think it's a great time to be in the industry. I actually think in the next 3 to 5 years, you're probably going to see an increase in the amount of money that is going to go into the broader telemedicine industry.
Yeah, I agree with that. So follow up to that, Dave, do you think more money will be placed in kind of business to business or provider to provider telemedicine, or more the direct to consumer build out?
It's an interesting question, and I don't know if I have the answer to that, other than I would say I think what you've seen historically is a lot of the initial money went into the consumer facing. Some of the companies that were mentioned, Teladoc, which is one of the only publicly traded companies in the industry. Doctor on Demand and some of those, they were all really consumer facing, right? They were playing to the consumer, and they had a bank of doctors that were seeing people. I think that was a slow adoption. So that's why you had, 4 or 5 really big players, and they were fighting for market share. I think where you saw in the last couple of years, the higher adoption has been in the so-called B2B. And that's what the world we play in. So, our customers are hospitals, and we're providing services to their patients and providing specialty services to their, on-staff docs. And I think you've seen an increase there. Paula mentioned, it's been an expansion away from just behavioral health into multiple disciplines. And I think you're going to continue to see that. And like any industry, as you see more and more growth, more and more technology advancement, then you're going to see the consolidation. And that's happening. That's happening on the consumer side. Teladoc and some of those other companies have been on an acquisition binge. And I think you'll probably see that starting to happen more and more in the next couple of years on the B2B side.
Yeah, I agree with that. And you touched upon technology. Dan, I want to kick it back over to you real quick and talk about the role that software plays in this. In the VC space. I see a lot of times in my day-to-day that we're investing into new technologies that actually help facilitate, whether it's direct to provider, direct to consumer. It doesn't really matter. We're just trying to build out that technology platform to make this more efficient. Can you just briefly touch upon what you see the role of software and investing in software is?
Yeah, I think software is really how it all comes together. And so the doctors have to make a choice. If I want to offer telehealth, I either need to, see if my existing EHR does it or find a solution. I agree with David that B2B is easier, because if the doctors have a solution and say, I'd like my patients to use this, it is far more easier than for a patient to say, doctor, I found this app I like, can you use it to chat with me? The doctor might have 50 of those conversations and 50 different apps to install. So if the doctors are on the front of this, and they let all their patients know, here's how you can connect with me, here's how we can stay engaged, that's the easiest. And VCs always ask that, who's going to pay for your software? And getting the patients to pay for it is very difficult to do, but getting the doctors to pay for it because they get reimbursed to do it is much easier. And that's, VCs always ask us that. The tool sounds great, but how do you get paid?
It's always my first question. So Paula, if you were an investor today, what areas of telemedicine would you personally be investing in?
So I think one of the opportunities is for enhanced features for anybody that's using a video device. Mm-hmm. So one of the things that we continue to struggle with, but struggled with early on, was the point that I made earlier about certain exam elements not being able to be done remotely. So unless the patient was in a center or in a clinic where a telepresenter was doing their vitals and doing their physical exam, we're really limited to what we can, to what we can see for a patient. So yes, you might be able to examine their skin, you might be able to note their general appearance, you might be able to ask how they're feeling, but you can't do a heart and lung check. You can ask the patient to take their own temperature, but you can't get their BP. So there are peripherals, there's devices out there, handheld devices that consumers can use. And one of the things that I just read, and Dan had mentioned Amwell earlier on, that Amwell acquired a company called TytoCare that provides those devices. The challenge with something like that, though, is it's expected that the consumer will pick up the cost for that particular device. I don't know what the costs are today. I know they were pretty expensive early on. Now, a patient could purchase it. They could use their flexible spending account, their medical spending account to purchase it, but will they? So I think there may be some opportunity for investment, but I think there's also some opportunity maybe for the health insurance companies to get on board with that, because in the long run, it's going to save them money. So that's one thing. Anything I think that makes it easier for connectivity for the patient. I think if we can get improved technology to make it simpler for physicians and patients both to be able to connect with the push of a button. Not sure what that looks like, but I think the technology could certainly improve. The last thing, this is just kind of a silly thing, but we've all become very adept at using Teams and Zoom and all of this new functionality. We have the ability to set these backdrops. So if you're at home, you may want to camouflage so that it looks like you're in an office, but then all of a sudden you're on camera and your head kind of disappears, it's really funny. So, I said to our folks at UPMC, we really need a UPMC backdrop for our physicians who are working in their bedrooms, because, we were on a staff meeting and I could see the physician with an unmade bed in front of him, but that backdrop technology may not quite be perfected. So whatever that looks like, I think we need some good corporate backdrops that don't make your head disappear. So there's some opportunities. I would invest in those companies. So
yeah, we're all trying to figure out the right protocol. And I think for the first couple of weeks of coronavirus, we were all, no matter if we were in a telemedicine setting or just a general meeting or an educational setting, or all these different new norms we're all trying to fix.
Yeah.
So before we leave this part of the talk, Dave, can you help the audience understand what are some of the common exit opportunities surrounding telehealth companies? You'd mentioned M&A, and there's one major publicly traded company, Teladoc. But do these companies typically go public? Are they purchased via an M&A to other financial buyers, or are they typically gobbled up by strategics? Or is it?
Yeah, I think historically, there have been few companies that have gone public. We mentioned Teladoc, which went public years ago and has been quite successful. I owned it at one point, regret the fact that I sold it, but it was one of the sole kind of pure telehealth companies that went public. And they have been on an acquisition binge and have been, acquiring companies with different technologies to help fill in. I think historically what you've seen is a lot of your smaller telehealth companies have been gobbled up by, other strategics, private companies, or have, sold themselves from maybe, a venture capital firm into a more mature PE firm that is looking a little broader, or maybe has some other portfolio companies. Again, I think the environment has changed. There's still a lot of uncertainty right now, but when life gets back to normal, I think you may see some opportunities for more telemedicine companies to hit the public market, and get a few more people out there, which would then over time increase the opportunity for consolidation. But like any industry, I think there's so many startups, there's so many people out there doing different niches here, that over time you tend to see industries mature and that consolidation start to happen. But I would say historically to this point, it has mostly been the exit has been to a strategic partner, not necessarily a public marketplace.
Yeah, I would agree with that. I think you're still a few years away. Right now, it's more of a Wild West. It's always a little different, niches being built out. I think in the next coming years, you're going to see either the public markets become more attractive, or you get some major later stage private equity firms just kind of building platforms and just kind of picking and choosing the select assets that they want to build more of a comprehensive offering.
I totally agree.
Yeah. So for the outlook of the industry, we've touched on the background, the challenges facing coronavirus and the investing landscape. Just want to kind of switch over now to what we all think what the outlook of the industry looks like. Paula, how can UPMC continue to take full advantage of telehealth? More specifically, how can UPMC incentivize its provider workforce to support virtual care? We learned, during this conversation that providers were kind of slower to adopt, but now with changes in reimbursement, I think there's broader acceptance of this platform. Again, how can UPMC continue to take full advantage of this model?
So some of it's almost happening organically. As the providers have become accustomed to telemedicine, they've found that there's more flexibility in their lives. So for some physicians, this is a good opportunity for them to work remotely, never even have to come into the hospital unless they have some face-to-face sessions set up. So some of the incentivization just has kind of happened on its own. I think some of the other things that we can do, aside from, physician contracts, we do set expectations. And so part of, rolling out telemedicine was really kind of setting that expectation that we really hope, or that we really expect that 30% of their encounters are going to continue to be virtual. So there's contractual things that we can do to help incentivize them. But I think the other thing that we can do is really just offer the support to our providers. And, one of the things that I really struggled with personally is when the patients were no longer coming into the clinic, when they were seeing the physicians virtually or the APPs virtually, we had office staff and nursing staff and medical assistants who really didn't appear to have a lot of work to do because the patients weren't here. So one of the things that we did, though, was be able to help the providers by utilizing those staff to be able to provide virtual check-in and virtual check-out, to be the technical hands here to be able to help those providers when they were struggling, or to be able to help the patients when they were struggling. So it became another opportunity that we never saw coming. Nurses, and this kind of goes along with some of the comments that Dan had made, nurses are really involved in helping to manage the care of that patient from encounter to encounter. So this became the role of the nurse, or this became the nurse's role even that much more important. So I think providing the support that we need to be able to make the technology flow a little bit more seamlessly, I think those are some incentives to help continue to drive, the full advantage.
Yeah, right. So you can kind of follow up with that a little bit, Paula. On the consumer side, I'm sure you're familiar with My UPMC, which is our consumer front door here at UPMC that allows to kind of put consumers in charge of their healthcare via their smartphone and online logging. How can a platform such as My UPMC continue to drive at least consumer adoption?
So we use it today. In order to have a video visit pre-COVID, you had to have My UPMC. We do have about 70% of our patients who have signed up for My UPMC. I think that there's still opportunities to continue to improve that technology to make it a little flow just a little bit better. I think there's still, I hate to use the word clunkiness, but I think it's still a lot of clicks. You got to download stuff, it's not always that consumer friendly. So I think that My UPMC, this particular platform is very, very powerful. So I think we can continue to improve upon it. I think, one of the things that's going to be interesting, and I just read this yesterday, is that Epic, which delivers our EHR, electronic health record, we use My UPMC, which is part of the Epic platform. But Epic is going to start to use Teams to be able to connect patients virtually. So I'm not sure how that's going to work with My UPMC, but I think that even Epic has noticed that there's an opportunity to do things a little bit more smoothly. Does that answer the question?
Absolutely. And it's one of the things I know that we're working on at enterprises with My UPMC is the improvement with patient scheduling. You have all these different disparate, providers out there, and having coordinated scheduling can be an issue. So, to your point, to make it a little more user friendly and less clunky, I know that it's, kind of on the forefront of that team's mind of trying to build out more of a smoother experience for the patients.
Yeah, I'm going to add one other thing to that too. You mentioned it. So, having UPMC Health Plan as our insurance company, if you have a virtual visit with Health Plan, you register. It's very easy. You register, you pay your copay, etc. With the current situation that we have with our patients using My UPMC, they don't really pre-register. They don't pay their copay. So I think there's some opportunities to make things look alike. And so being able to do those front-end processes and collect the copays is also going to really help. So, and I think it'll help the patients too to understand some of the expectations that come along with, it's still a visit. So.
Yeah, that's a great point. Dave, from an industry perspective, how do you see telehealth evolving over time? Namely on the consumer side, again, the provider side, as well as reimbursement and regulatory aspects.
Yeah, so a couple of pieces there that so overall, I think this is, and use the analogy of banking, you can go back to days where, everybody went to the bank, right? You needed to check cash, you went to the bank. Then the ATM machine came out, and some people did and some people didn't. And now today, you take a picture of a check with your phone and you transfer money through your phone. And I think we're on the early stages of that from a consumer point of view. And I think, generationally, I've got two young boys. They will 90% of their healthcare will be done via mobile application. So we're early stage. This was the year where I think general acceptance happened, but we'll see continued adoption. We'll see, continued advancement. I think interoperability needs to be addressed. And what I mean by that is, still there are too many disparate systems and disparate softwares that don't talk to each other. And so if we really want to get this for the patient's benefit, we've got to get to the point where we're sharing records and the devices are more easily input in and out of EHRs and everything. What was the second part of your question? question, Craig?
Reimbursement and regulatory.
Yeah, so that's one where I think we're already seeing it. Again, you know, and I think Dan said this earlier, the biggest hurdle I think from a doctor accepting this was it was reimbursed at a different rate or not reimbursed. I mean, Medicare in many instances didn't reimburse, right? So why would you see a patient virtually when you could bring them into the office and get paid?
Right.
That has changed with the emergency rules here with COVID. You know, we'll see what happens, you know, politically, but I would say that I think, you know, what may happen is some of those will be pulled back, but I think there'll be a public outcry. And I think, you know, what we're going to see is over time, Medicare, Medicaid, and then the insurers following suit and starting to really recognize that, you know, a patient visit is a patient visit, whether you're going into the office or you're doing it virtually. I said earlier, there's going to be a nice blend of people figuring those models out. When's it appropriate for virtual? When's it appropriate to come into the office? And that'll be a big part of the future adoption, is getting those reimbursements in place, stable and comparable. And then I also think following that will be the regulatory piece of this, because that is, you know, for those of us that are on the operating side of this, that is quite a hurdle. I mean, again, when you're dealing with 51 different regulatory bodies and licensure rules, you know, neighboring states can have diverse descriptions and definitions of what telemedicine are. We're starting to hear some of that. You know, there's been some push to have, you know, states grouped together, and if you're licensed in one state, we can make the licensure easier in a neighboring state. But we need to see more of that. We need to see more of a regulatory easing or commonality, and that'll take some of the back office burden, you know, away from you know, being able to grow and mature these businesses.
Exactly, and even from an investment standpoint, you know, having 51 different rules and regulations, it's tough to scale. A lot of these businesses, it just kind of takes time, and as you said, unnecessary back office costs. And so as that becomes more streamlined, you know, I think that'll also be a benefit from an investor perspective as well.
Definitely, because, you know, that'll be money that can be invested back into the business. Right now, it's a lawyer's dream.
Dan, can you discuss the importance of telehealth for payers and the expected increase of coverage or reimbursement?
Yeah, I think it's exciting what we've seen in the last year. And when you have a push at the federal level, Medicare tends to take the first run at it. And they went all in March, and, you know, making these visits E&M. There's care management programs, and Paula touched on it. A lot of these can be done by nurses, so they're very cost effective, even medical assistants. So it's a service that doesn't cost the payer too much, but the benefit that you get in terms of wellness and prevention, keeping people out of the emergency room, and payers don't want to pay that expense. That's expensive. So if I could do a telehealth visit to make sure my chronic patient is okay, and oh, let's get your meds refilled, or something so simple, I think that payers should be very incentivized. So I hope it increases even, you know, once things get back to normal. I hate to say that it's a fad and it'll go back, but the good news is millions of people liked their telehealth visits this year. If they had a good experience with it, and I'll speak for myself, I got poison ivy this summer. I get a telehealth visit, I showed my arm. Why would I ever go back to the clinic to do that? It took 10 minutes. So once I think you like it, and the payers make it affordable, and the doctors are comfortable with the technology, I think, like David's example with the bank, you know, why would you go back? So I hope that the incentives continue to grow. My wish would be that there would be fewer copays. Medicare charges copays for a lot of things on the care management side. So hopefully those go away, and then you take every possible barrier away from the patient. But overall, I think it's a good trend, what we've seen happen in the past year.
Yeah. So before we get into our last question, I want to dig into a little bit on value-based contracting. Just a quick reminder, if anybody has any Q&A, feel free just to send it on your Q&A icon there at the bottom of your screen, and I'm happy to address it with each of the panelists. So that being said, Dan, back to you. You know, can you talk a little bit how health plans look to align incentives with provider networks and accelerate perhaps this value-based contracting? I know that's probably a whole hour and a half topic in and of itself.
Yeah.
I'm aware, but as you deal with your services, oftentimes help chronic patients, having this value-based, payer provider incentives across, can you just kind of just touch on that a little bit?
Yeah, and Medicare is really good at this part. They rolled out these quality-based payments where if you achieve a certain level of quality in your patients, you hit certain metrics, and many doctors even got to pick their own quality measures. And so before, when this first came out, doctors thought it was a hassle, but now you can kind of, look at your population as a whole and figure out where are my gaps? What do I need to do? And telehealth brings a whole new set of tools to doctors who might have been struggling with quality measures before. And the good news is you get paid if you do these things. So it's a win-win. The patient gets services that might have been overlooked because the doctor's incentivized to provide them, and the doctor gets payment bonuses if they meet their measures and if they truly provide value to the patient. So when you have a win-win scenario like that, I don't see any reason to stop doing it or to go back the way it was. So I think it's a really good thing that this is kind of going to give a push to value-based care.
Sure, great. So last thing, I'm going to put everybody on the spot, and I apologize in advance. Paul, I'll start with you. Any final remarks, anything that we didn't cover here today that you just want to touch upon, anything that interests you, where you see, any additional thoughts on the outlook, investing landscape, etc.?
So the only, just a couple of really quick things. One is I just want to jump on to the value-based payment methodology as well, just to add on to what Dan had said. Not only do we see a reduction in the number of emergency department visits, but telemedicine can also help with readmissions to the hospital. And I'll give you a case in point. I mentioned earlier our long-term outpatient antibiotic program. So patients who go home on IV antibiotics that are on those antibiotics for a really long time, those drugs can be very toxic to the patient's system. So we have what's called OPAT, which is outpatient antibiotic therapy, where our nurses and our pharmacists really are managing those patients long-term. Through the beauty of telemedicine, we can see those patients a couple of times during the course of their antibiotics, and we have statistics that show that those patients who follow that program don't go back into the hospital. So we are in the process of negotiating right now for improved reimbursement for that particular example. So I wanted to throw that out there. The same as Dan had mentioned, remote monitoring, taking care of a patient who has diabetes and have them do their testing every day keeps them from going into the hospital or, needing to rely on more expensive therapies. So there's so many benefits to this that you just don't see right from the very beginning. So the only other thing I wanted to say is, in the different opportunities that are out there for patients, Sam's Club is now going to offer $1 virtual visits. Walmart has done $4 virtual visits. Copays have been waived during the time of COVID. That's coming to an end for many of the national health payers. It's got to be confusing for the consumers. So to be able to get us all on the same page and to be able to maybe leverage what some of those industries are doing, I think if we could do that, healthcare and Disney went together. I think healthcare needs to look at what is happening out in the commercial market and see if we can do things better that are more appealing to patients, because it's got to be confusing for them.
Absolutely.
Thanks.
Absolutely. Great points. Dave's in. Any final remarks?
Yeah, to follow up on some things Paula just mentioned, and I'll use our business as an example of, the ability to kind of marry the quality and the effectiveness and the cost savings for all participants. So, again, we bring a very important expertise and specialty to these rural markets that without, I had a prospect, I was talking to the CEO, and, the doctor said, well, what do you do for your infectious disease patients? Well, he said, well, we muddle through. And I thought, not quite sure I want to put my loved one in the hospital where they're muddling through, or they transfer them. And if you think about it from a quality point of view, if you can keep that patient in their local community and give them high quality service, it's safer. It's more convenient for the family who, if you transfer them into the city, has to then find, care and transport. And for the hospital, it's a revenue source. It's a quality reputation issue. And, when you're transferring people back and forth, there's a huge expense. So there's so much positive that comes out of being able to take that specialty care and deliver it bedside. And I think that people are just now starting to recognize that. Dan mentioned, I think a lot of your insurers are going to be doing a lot of ROI analysis on these things of, geez, if I may reimburse a little bit more for a certain consult, but all of the downstream costs that I'm saving will by far prove to be a positive business plan for them. So the other thing is, and this is again part of our business, is antibiotics are things that and Paula mentioned this about monitoring people that are on long term. Antibiotics overall can have side effects and can be unhealthy for patients. So bringing an expertise again to patients that didn't have that and being able to get them off of antibiotics sooner are better for them, and it's better for kind of the world as a whole. Because one of the biggest concerns of antibiotics is the resistance that happens if they're overused. So again, another business case or another ROI value point of being able to touch more patients efficiently and effectively.
Dave, that's a great last point. It's often overlooked just how effective telemed can really be in all its different touch points. Not only we've been really focusing on the payers and providers in this conversation, but to your last point, the broader epidemiology of this and large swaths of populations as it relates to just overall care, of course, but even antibiotic resistance. As these bacteria and viral strains mutate, they themselves adopt to the therapies that we've created and become more and more resistant to treating the broader population. So there's really just not a place where telemedicine can't be effective. Dan, finally to you.
Yeah, I think the exciting thing that I see is that I don't ever remember a time when doctors and payers were more eager for innovation in this industry. And it took something like this where for any startups that are on the call today, this is a good thing where, doctors are busy people and it's hard to get their attention, but if you have a great idea and you make their life easier, I think more so in the last year than I've ever seen, they want to listen. And if you have something that helps their patients and improves care and reduce costs, the timing is good for innovation in our industry.
Appreciate it. Well, thank you all very much. Those wonderful answers. Appreciate the participation. Hopefully everybody in the audience enjoyed our conversation this afternoon. And so once again, to the audience, thank you all so much for attending today. A survey link will pop up on your screen following the call, and your feedback is greatly appreciated as we move forward with virtual programming. This is a bit new for us, as you know, and so your feedback is certainly welcomed and appreciated. Our next PVCA event is the Three Rivers Venture Fair on October 28th and October 29th. For more information, please visit 3rvf.com or reach out to Micah Whitfield or Ian Shakow. And our next regular virtual event will be in November, and we'll explore the cryptocurrency impact on the VC industry. Stay tuned to your emails for more information as the event gets closer. Thank you all again for joining, and enjoy the rest of your day.